Welcome this afternoon. We are here with Ultimate Opinions in Medicine at our lung tumor board. My name is Mark Sosinski, and I'm the Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. I'm joined by my four panelists. I'm going to have them introduce themselves. I'm going to start with Dr. West.
Hi, I'm Dr. Jack West. I'm a medical oncologist with a focus on thoracic oncology. I'm an associate clinical professor at the City of Hope Comprehensive Cancer Center in the Los Angeles area.
Hi there, I'm Kristen Higgins. I'm a radiation oncologist at Winship Cancer Institute of Emory University in Atlanta, Georgia. I specialize in thoracic malignancies, and I'm an associate professor and could be here discussing cases with everybody.
Hi, I'm Varun Puri. I'm a thoracic surgeon at Washington University in St. Louis, and I also serve as a professor in the department and the program director for our cardiothoracic surgery residency program. Glad to be here.
Hi, I'm Michelle Ginsberg. I'm director of cardiothoracic imaging at Memorial Sloan Kettering Cancer Center in New York City. I'm also vice chair of education in our department and professor of radiology at Weill Cornell Medical College in New York.
Here is the case presentation. It's a 66-year-old male. He is a current smoker with a 60-pack year exposure. He has newly diagnosed stage 4 squamous cell carcinoma of the lung with bilateral lung nodules, and we're told painful supraclavicular cervical and axillary adenopathy. We're told he's PD-L1 negative, and the question is, what would be the next step in management? If you look here, again, as I mentioned, he presented with, in addition to painful swelling of the neck in axilla, some fatigue as well as shortness of breath. We're told that his performance status is an ECOG of 2. His past history is significant for atrial fibrillation on anticoagulation. He does have a history of coronary artery disease. He had a myocardial infarct in 2015 requiring stent placement, history of heart failure, but a recent ejection fraction is 55%, some hypertension and COPD. As I mentioned, he was a current smoker with a 60-pack year history of exposure and no family history of malignancy. So I'm going to turn it over to Dr. Ginsberg to review some of the radiographic findings.
This is a CT scan which demonstrates a left upper lobe mass. Additionally, we see mediastinal lymphadenopathy and a small right pleural effusion. We can advance to the next slide, which will demonstrate the PET-CT findings. And this study shows that there's extensive lymphadenopathy in the mediastinum, both on the right and left side, and extending also adenopathy in the supraclavicular and cervical regions and axillary regions. In addition, there was also a right hilar lymphadenopathy, which is not demonstrated on this study, and a moderate-sized right pleural effusion.
All right, thank you. So we're told that he has a ultrasound-guided fine needle biopsy of the left axilla. The diagnosis histologically or cytologically appears to be squamous cell carcinoma. We're told he has a PD-L1 of 0%. He has a negative brain MRI. He gets palliative radiation because of the pain that he presented with. And then we're told that he initiated palliative systemic treatment with carboplatin, nab-paclitaxel, and pembrolizumab. So why don't we start the discussion? Let me ask Dr. Higgins. In patients like this, we're told that he was having pain. You know, obviously we weren't told exactly the details of that pain, but just your approach to the palliative treatment. And we see here this was 30 gray and 10 fractions. You know, what are the radiotherapy options, assuming you have a focal area of pain in a situation like this?
Sure. So, you know, I think that this is an important question, and it's a little more nuanced. I don't like to start with upfront radiation for every patient that has pain necessarily, because it can delay systemic therapy. So I will generally sort of make an assessment about the burden of the disease that the patient may have, and usually my medical oncologist and I will discuss how quickly we think the patient could get started with systemic therapy. If it was somebody that needed molecular testing, for example, we know that there would be a several-week delay, and in that situation, we tend to start with more upfront radiation. But one of the things I worry about as a radiation oncologist is always dogmatically starting with palliative radiation when anybody has pain, because sometimes we can control pain with other methods, and I think it's a balance of not delaying systemic therapy too much. Certainly, also, we're moving to shorter courses of palliative treatment. The traditional fractionation schema for palliative radiation was 10 fractions delivered over a 2-week time period. We could do something like this, I think, in 5 fractions just as easily. The duration of the palliation may not be as long. You may need to come back and treat the patient again if they start to progress in those sites. And that's okay, because again, it'd just be another week, down the road. So I think it should be a conversation between the radiation oncologist and the medical oncologist, and really, try to figure out what is the most urgent step in the therapy for the patient. But generally speaking, the radiation is effective in getting rid of pain and helping the patient feel better and improving quality of life.
I'm sorry, I was just going to jump in and say one other factor. I totally agree that at the end of the day, it needs to be a judgment based on the case and how clearly there needs to be palliation. One issue when you do the radiation is you can't effectively use that radiated area to assess response, and you also don't have the feedback of how that patient's pain is changing over time to kind of assess in between scans how a patient may be doing. But that said, in cases you need it, you just need to do that and not look back. And particularly if there's other areas to follow, it's really not a big issue.
So Dr. Higgins, one of the things that you mentioned, a delay in systemic therapy. Every once in a while we have these cases where we start systemic therapy, and then if you have a painful, a single painful bone site, offer a course of radiation during the first cycle of chemotherapy. I think we make a judgment call about the safety of that. But any thoughts on interspersed palliative radiotherapy with chemotherapy in a patient like this?
Yes, we do that, I think, very frequently, wanting to get the systemic therapy going first. And generally speaking, for bones, there really isn't much heightened toxicity with taking that approach. We're a little bit more careful when it comes to treatment of the brain. We wouldn't want to overlap brain radiation with systemic therapy infusions. But certainly for bones and even chest radiation in between cycles is very safe.
Dr. West, let me ask you the next question. I actually have a couple of questions for you. And it's based on some of our experience at our center, where we've looked at a little bit about the difference between measuring PD-L1 on fine needle aspiration versus core biopsies. Most of the trials that established immunotherapy as a standard of care did require a core biopsy for PD-L1 testing. The fact that this gentleman is labeled as having 0% PD-L1, but we're told he just had a fine needle biopsy. We don't know the robustness of that biopsy. Does that give you pause or any concern in any way, shape, or form?
I don't think it does. I think there's plenty still to explore about the nuances of how we do PD-L1 testing, but we also know that that's not perfect. It's neither necessary nor sufficient to benefit from a combination. I would say in someone who's PD-L1 0, the evidence is clear, not just from the trial that his treatment was based on, Keynote 407, but from several other trials of chemoimmunotherapy, that the benefit conferred by addition of a checkpoint inhibitor is present and real in that PD-L1 negative subset as well as PD-L1 zero. So in a sense, it doesn't change the management effectively in my mind. Moreover, I think that as somebody who has a pretty significant extent of tumor burden, not mutational burden, but the actual extent of disease and the symptoms, this is somebody who I'd want to kind of throw in both modalities, give the best shot on goal up front to try to get some good control over the cancer. So I think it's an issue, but it wouldn't practically change how I approach his case.
So this gentleman is a current smoker, 60-pack years, squamous cell carcinoma. Any role for molecular testing in this patient?
I think that the pretest probability is quite low, but you as Wayne Gretzky said, you miss 100% of the shots you don't take, and I have seen a recent case that I evaluated from another place of somebody who had a MET exon 14 mutation in a current smoker with a squamous cancer. That's not common, but it's not zero. I would characterize several of the targets that we're looking at as similarly not zero. I wouldn't want to put too fine a point on it and say that this is evidence-based and there's a strong pretest probability, but under the you never know, and it certainly is great if you find it, sure, I would say if the patient isn't going to get saddled with a significant bill, I think it's nice to look, because every once in a while it does pay off.
And we're told here, Dr. West, that the patient has a performance status of 2. Realizing you mentioned this patient was treated kind of along the lines of Keynote 407, which really was restricted to ECOG performance 0 to 1 patients. What are your thoughts about extending the the results of that trial to a PS2 patient? Is something you commonly do in your practice?
The short answer is yes. I think that there are not a lot of trials that generate much data for patients with a performance status of 2, but we have overall the data that we've seen with patients with a more marginal performance status is that they benefit from carbo doublets more than single agent, and that patients who get whatever benefit they can get, or basically the patients most likely to benefit from immune checkpoint inhibitors also do benefit if they have a more marginal performance status of 2. So I would say that in the absence of good data to clearly say what we should do, we always every day have to extrapolate about, yes, this patient wouldn't have been on that trial because their creatinine is a little high, or whatever in their past medical history, they might have a second malignancy. That's part of what we do in oncology. I know you must do this every day too. You have a patient in front of you, and in fact, a lot, and I would say the majority of patients with advanced lung cancer would not technically be eligible for many of the trials we have. So we have to extrapolate them appropriately as best we can with judgment. In the real world, I would not hesitate to pursue, especially a regimen like carbo nab-paclitaxel with pembro, because that carbo nab-paclitaxel has also been looked at and found to be quite feasible in patients with a performance status of 2. It's a weekly administration, so you can get regular feedback on how that patient is doing clinically, adjust as needed.
Yeah, I would agree. In my practice, I have frequently actually treated patients that are closer to PS2. And I think in a patient like this, I always look at it as you kind of have a window to make a difference and to palliate the patients. And so I am very comfortable treating patients with PS2 status in extending the data from the trials. Let me ask you also about the choice. As you well know, Keynote 407 allowed both solvent-based paclitaxel as well as nab-paclitaxel. There is some sense that perhaps maybe nab-paclitaxel may have a bit more activity in squamous cell carcinoma. You mentioned it's weekly administration versus solvent being every 3 weeks. Is that your preferred taxane, the nab-paclitaxel in this setting, or do you think there's a role for solvent-based paclitaxel every 3 weeks?
Well, I think there's certainly a role. It's not wrong, but I agree with everything that you said. And you were one of the people who was kind of pivotal in shaping our view based on some of what you've presented with nab-paclitaxel. And I would say the data are not completely clear about how much of an incremental benefit there is with nab-paclitaxel over solvent-based in the squamous population, but it's not worse, and it may be better. And the data from Keynote 407 also show that the data are at least as good, if not marginally superior, with nab-paclitaxel. It is my preference. I just wouldn't put too fine a point on it. You have to pick one, and it is what I would prefer if I had a patient for whom traveling in was a real hardship, or for whatever reason it just couldn't be done. I wouldn't say at all that the every 3 week solvent-based is incorrect, but I prefer the nab-paclitaxel. And in a patient where I want to get regular feedback, I think that's a feature, not a bug.
So a couple of thoughts to kind of before we transition to the next case. We're told the patient got started in June of 2019. I assume, Dr. West, you stopped the carboplatin nab-paclitaxel after 4 cycles?
That's right.
Yeah.
A great paper that showed that 4 cycles versus ongoing didn't show a benefit.
Yeah, and do you? What about the pembrolizumab? Do you look to continue that for 2 years?
Yeah, I think 2 years in general, in the absence of a clear reason not to. If someone is running aground with toxicities or there's financial issues, okay. We don't know. I think that the 2 years is empiric. It's what was in the trials, but that's the best we have. So I think going out to 2 years, if there's not a contraindication, is very appropriate. I think there at that point we scratch our heads and have to individualize a bit.
I was going to say, what do you discontinue at 2 years, or do you individualize the choice?
I really do individualize it. I mean, it's based on, at that point, it's based on tolerability and not just totally prohibitive issues, but I have quite a few patients who have musculoskeletal issues, their knees or their wrists or, various things. They're getting arthralgias and we don't know. I mean, these are generally, we know people can get joint pains as you get older for all sorts of reasons, but it seems to be a common concern in many of my patients. And so we talk about that. We see how much, if there's no evidence of residual disease, I'd feel more comfortable stopping. Maybe at that point do a PET scan to look at whether what's residual on the CTs that I usually use to follow are PET avid at that point or not. These are the kind of factors I would use. If a patient really strongly prefers to remain on treatment, has no issues, and particularly, has some disease that I think could be prone to flare up, I would be more inclined to continue in the absence of a reason not to.
And then just very briefly, if the patient were unfortunate to have disease progression, what would be your go-to second-line treatment for this patient?
It would be docetaxel with consideration of ramucirumab. I think ramucirumab has a modest survival benefit associated with it, and it's just not incredibly compelling, and it certainly I think, an open question in someone who has a more marginal performance status, particularly maybe someone who may have been beaten up by chemo and maybe prone to greater myelotoxicity, myelosuppression. But I would basically say docetaxel and consider, based on the patient in front of me, whether to add ramucirumab. And then I would also consider that there are data with afatinib as well. It's not something we often think that much of. It's was shown to have a very modest survival benefit over erlotinib, which itself is kind of damning with faint praise, but there's an indication and it's oral, so it's something that might be considered as well down the line.
Yeah, I typically use that as a third line option if patients get that far down the road. So to summarize, we agree with the management in this particular case. The choice of regimen is the regimen from Keynote 407. Both Dr. West and I favor nab-paclitaxel in this setting. We would hopefully give 4 cycles and continue immunotherapy for 2 years, individualize whether or not we would continue it beyond 2 years. And if the patient were unfortunately to progress, I agree with Jack. I typically use docetaxel most often with ramucirumab unless there's a contraindication for this.